Hello, and welcome to this webinar sponsored by Doctor's Data. My name is David Quigg, and over about the next half hour or so, I will provide a clinical overview of celiac disease and laboratory testing specifically designed to assess celiac disease or gluten sensitivity. Now, right from jump, I want to emphasize the importance, the magnitude of the effects of this disease. And here I'm showing a picture of a biopsy from a normal patient, that is from the duodenum, where you can see the very lush, vascularized villi just waving around and waiting to absorb nutrients. In contrast, on the right, you can see a biopsy from a celiac patient from an affected region of the small bowel, and you notice the lack of villi and the knobby pigskin-like texture. Now, analogously, we can look at this a little bit closer to home and envision such as a beautiful forest, say in the Northwest, where we have these very plush pine trees brushing back and forth in the wind. In contrast, we have a view of a forest, basically a forest on gluten, sort of like this is your brain on drugs. And in the celiac forest, you can see the patchy nature, the lack of trees or villi, and the pores. Now, keep in mind that even in patients with celiac disease that have been off of gluten for some time, some of those patients may not have complete recovery of the integrity of the small bowel, and you may not see complete, nice, full, bushy villi. So what I want to cover today is celiac disease and non-celiac gluten sensitivity. I want to talk about latent or delayed onset celiac disease and state of the science antibody testing, that is the serology, which is the standard of care. Also, I want to talk about testing to support individualized clinical and nutritional aspects with respect to the patient, because celiac is a major malabsorption phenomenon. Now, celiac has been referred to as gluten-sensitive enteropathy, and it affects people of all ages around the globe. It's an autoimmune disease that occurs only in genetically predisposed individuals, that is, those with the HLA-DQ2 or DQ8 halotypes, or genetic variations in several non-HLA genes. Now, the disease is triggered, of course, by the ingestion of gluten, which is a very difficult to digest protein composite found in wheat and similar proteins in barley and rye. It causes an aberrant immune attack that damages not only the villi in the small bowel, but also the pancreas, type 1 diabetes, the skin, dermatitis, herpetiformis, and even the brain, where it attacks the Purkinje cells in the cerebellum, and that's when we get the gluten ataxia. And it has been demonstrated that about 60% of celiacs with gluten ataxia actually show cerebral shrinkage on MRI. So it's pretty serious stuff. Celiac disease is clearly a malabsorption issue and can be associated with not only malnutrition, but specific nutrient deficiencies. Things like iron, zinc, selenium, folate, B12, fat-soluble vitamins, and essential fatty acids. So the symptoms of celiac, most common in young children, failure to thrive. But in everyone, diarrhea, gastrointestinal inflammation, bloating, cramping, foul, fatty stools, Malabsorption of fat, the slowest to be absorbed macronutrient. Weight loss, fatigue, muscle weakness, thyroiditis, dermatitis herpetiformis, and anemia. Now, less common are psoriasis, osteoporosis, peripheral neuropathy, ataxia, recurrent pericarditis, vasculitis, unexplained infertility, amenorrhea, and pancreatic exocrine function, that is, insufficient digestive enzymes. So not only pancreatic endocrine, but pancreatic exocrine dysfunction. So pretty serious plethora of symptoms can be expressed in these patients. There are also increased risks, and I emphasize risks, associated with celiac disease, and those include type 1 diabetes, spontaneous abortions, preterm delivery, gastrointestinal lymphoma, and adenocarcinoma, esophageal cancer, and non-Hodgkin's T-cell lymphoma. Now, it has been suggested that some of these cancers may be associated, in fact, with the comorbid nutrient deficiencies. Now, we have this phenomena called latent or delayed onset celiac disease, which is really interesting because most cases of celiac disease are detected and diagnosed early in life, infants, toddlers, young children. However, celiac disease may not be fully expressed until about the 4th decade of life in adults. And in those individuals, they could be completely asymptomatic. They may only have extraintestinal symptoms or even mild gastrointestinal symptoms. Now, we really don't understand the reason for this latency for expression of celiac disease. However, Dr. Fasano has hypothesized that since the microbiome can influence gene expression, sudden or progressive change in one's microbiome might cause formerly quiescent susceptibility genes to become active. Again, this is a hypothesis. Time will tell, but it's a real phenomenon. Now, gluten sensitivity is absolutely not just a fad. It certainly is trendy, but I take a quote from the Mayo Clinic. When people with GI diseases such as celiac, non-celiac gluten sensitivity, or catch-all IBS consume gluten proteins, they can become sick. So it's official, folks. Gluten sensitivity is real. In fact, we can test for that. So non-celiac gluten sensitivity is very much like celiac disease symptomatically, however, without the extensive intestinal tissue damage. Now, non-celiac gluten sensitivity appears also to be associated with intestinal permeability, autoimmune conditions, systemic inflammation, neoplastic disorders, neurological diseases, including dementia, and peripheral neuropathy, as well as brain fog. And everyone has heard a friend or a relative say, man, when I eat pizza, I just get stupid. Now, it's very important in understanding how and why we use the serology testing for the antibodies to understand the inside setup, and that is the genetic predisposition. Now, 95% of celiacs, not all, but 95% of celiacs carry a gene for either the HLA, DQ2, DQ8, or both. And again, other genes are suspected. Now, the HLA DQ proteins present or display antigens to immune cells. Those antigens include the gliadins, modified gliadins, the enzyme, tissue transglutaminase, and gluten fragments. So what we see is the HLA proteins presenting the antigens to mature immune cells, giving them the signal to go ahead and attack. So the antibody trail is really interesting, and I do like to refer to it as a trail. and it'll become clear in a minute. Now, first, we have gliadin, gluten-induced increased permeability, breakdown of the tight junctions. That permits the influx of the gluten particles, if you will, or gliadin molecules to come in through paracellular transport. Now, that gluten fragments or gliadin causes an immune response by the lymphocytes underneath the enterocytes such that they attack the enterocytes. When they attack and break down the enterocytes, it releases their intracellular enzyme called tissue transglutaminase. Now, that tissue transglutaminase modifies gluten peptides into deamidated gliadin peptides, okay? Then mature activated immune cells release antibodies against the tissue transglutaminase and the deamidated gliadin peptides. So concomitantly, we have activation of natural killer cells, which further beat up on the enterocytes. However, this release of these antibodies by these mature immune cells are not really known to cause damage to the enterocytes per se, but rather they provide us with an incredible tool so that we can follow this trail of evidence towards the detection of celiac and non-celiac gluten sensitivity with a high degree of confidence. That is a very high positive predictive value of the serology testing at about 98%. So if we look at a cascade of the diagnosis of celiac gluten sensitivity or non-celiac gluten sensitivity and wheat allergy as dictated by the American College of Gastroenterology, we can see that when we have IgA, IgG elevations against the tissue transglutaminase or the DGP, any of those being positive, we should consider celiac disease. If those are negative, then we look at the antibodies towards the antigens, IgA, IgG to gliadin, and IgG to gluten. If any of those are positive, and we don't have positive antibodies for the tissue damage, we should consider gluten sensitivity. Now, if none of the antibodies to the antigens are positive, then we look at IgE for wheat, which if positive will tell us that there is a true wheat allergy. So just again, just to summarize, for celiac, we look for the TTG and the DGP as an indication of severe tissue damage. For non-celiac gluten sensitivity, we look for antibodies against the assault of antigens, that is the gliadins and gluten, but not for, we don't see the tissue damage antibodies. Now, it's important to appreciate that serology test results alone are not diagnostic. The results should be considered in conjunction with the patient's symptoms, immune status, diet, genetic predisposition, medical history, and other laboratory test results. Now, the HLA-DQ genotyping should be used to exclude celiac disease. That is, you can only be celiac or make a diagnosis of celiac disease if, in fact, the HLA-DQ2 or 8 are present. If not, you cannot have celiac disease. With positive serology testing for the tissue damage markers, upper endoscopy is recommended with at least 6 biopsies from the duodenum. That is currently a point of controversy. So let's look at an actual test result, and this happens to be a patient, 42-year-old male, who developed delayed onset or latent celiac disease. So his 42-year-old male suddenly had intermittent diarrhea, fatigue, muscle weakness, and an unintentional 20-pound weight loss, went from 145 pounds to 125 pounds over a period of a year. And sure enough, with serology testing, we could see a marked elevation in the IgA for TTG and DGP, so significant tissue damage consistent with celiac disease, and not surprising, the elevations in IgA and IgG for the gliadin antigens. No wheat allergy indicated here. Now, not shown, but very important whenever you're doing serology testing, specifically looking at IgA levels, it's always important to measure total IgA so that you don't get a false negative. And I just didn't show that. It is present on this report. Also, very importantly, it is absolutely necessary that patients be on a gluten-inclusive diet for the serology testing to be valid and truly quantitative. Now, the serology testing can also be performed from a dried blood spot. The only limitation here is that you can't look at the antibodies against tissue transglutaminase, because when you elute the serum component from the dried blood spot, there is a massive release of red blood cell tissue transglutaminase. So as a backup, we can look at the IgA and IgG for the deaminated gliadin peptides. In this case, they were negative, but lo and behold, IgA was significantly elevated against gliadin. So here we have a clear case of consideration of gluten sensitivity. Again, total IgA was measured so that we don't have a false negative for DGP. Now, it's also important to keep in mind that the most accurate biomarker for celiac disease in children 2 years and less of age is actually the DGP. So there that's why this test lends itself so well to very young children and toddlers, particularly under the age of 2, because we have the fallback DGP. Now, one might question the validity of a blood spot. A lot of people are skeptical. There's a lot of things you can do with blood spots. And here I show the incredible correlation between the levels of DGP IgG from a dried blood spot versus from serum. And you can see an incredibly tight correlation, essentially identical results. Now, this test is so valid from the dried blood spot that it is currently incorporated into a huge prospective study of celiac disease in high-risk children, that is with first-degree relatives with a diagnosis of celiac disease. So this dried blood spot approach lends itself very well to testing children, young children who don't like to be stuck in their with a needle, simple finger prick, and then a cool Band-Aid put on there, and also available to practitioners who do not do blood draws. So a summary of the clinical information. Currently, there is absolutely no cure for celiac. There are pharmaceuticals in clinical trials, but that is never going to replace the requirement of a lifelong adherence to a strict gluten-free diet. Celiac disease is underdiagnosed. The sooner it's detected, the better. And it's recommended to test patients with a family history, including a family history of type 1 diabetes. Now, it's clearly an absorption problem, so specific nutrient deficiencies should be addressed. And non-celiac gluten sensitivity can be associated with very similar symptoms as celiac without the extensive tissue damage. Summary of laboratory. Sensitive immunoassays can detect a likelihood and differentiation between celiac, gluten sensitivity, and true allergy to wheat. Again, for celiac, we look at antibodies for the tissue damage, TTG and DGP, non-celiac gluten sensitivity, antibodies towards the antigens, and for wheat allergy, wheat IgE. Further, specific testing, because this has such major potential for malabsorption, specific testing can facilitate individualized clinical or nutritional intervention to support patients with celiac and non-celiac gluten sensitivity. That would include a very comprehensive stool analysis to evaluate gastrointestinal health and function, absorption, inflammation, butyrate production, essential elements, red blood cells or whole blood, fat-soluble vitamins, looking in serum, as well as RBC, essential fatty acids, and the folates, looking in serum, the primary folate being 5-methyl tetrahydrofolate, but also tetrahydrofolate, folinic acid, and the nasty unmetabolized folic acid. It's fun to say UMFA, and that's a whole nother story for another webinar. So I thank you kindly for your attention, and if you have any questions about the testing provided by Doctor's Data, please visit doctorsdata.com or call our 800 number. I thank you kindly for your attention.